Good morning. I'm Vijay Iyer, Chief of Cardiology at the University of Buffalo and Chief of Cardiovascular Services at Kaleida Health. It's my pleasure to talk to you today about transcatheter aortic valve replacement. The talk is titled From High Risk to Anyone. We're talking about the evolution of valve replacement done with a minimally invasive approach. Aortic stenosis is a fairly common condition, especially in the elderly. The prevalence of aortic stenosis is increasing as the population ages. This graph tells you the incidence of aortic stenosis over the last almost century, and you can see that we have a fairly substantial number of individuals with this condition. It is typically seen in elderly patients above the age of 75 or 80. However, a number of patients who are born with a congenitally abnormal valve, which is called a bicuspid or a two-leaflet valve, may manifest with this condition much sooner in their life. Aortic stenosis, once it becomes symptomatic, has very poor prognosis. This paper from Eugene Braunwald in the 1960s shows the precipitous decline in survival once symptoms of angina, syncope, and heart failure develop. However, in most elderly patients that we see today, the commonest manifestation is fatigue and not necessarily angina or shortness of breath. And the first symptom of aortic stenosis in the elderly may be fatigue. It is important to note that untreated aortic stenosis has a very poor prognosis. This is a graph that shows you the prognosis of a number of metastatic cancers, and you can see severe inoperable aortic stenosis has prognosis which is very similar to that. In the past, when patients did not have any possibility of their aortic valve being replaced with surgery, there was nothing to offer other than medical therapy, and their prognosis was extremely poor, not just in terms of survival, but also in terms of the number of days spent in the hospital. It is extremely important that timely intervention for aortic stenosis be performed. For symptomatic aortic stenosis, the treatment of choice for most low-risk patients continues to be open heart surgery. However, transcatheter aortic valve replacement is fast becoming a replacement for almost anybody above the age of 65 and for selected patients below the age of 65. This is an echocardiographic index of how we define aortic stenosis. And I think the important thing to remember is that when the aortic valve area is less than 1 centimeter square on an echocardiographic report, those patients should be seen by a cardiologist or by a structural heart team to make sure that we are identifying the appropriate patients. In addition, there may be some patients who may be very symptomatic despite a valve area that is slightly above 1 centimeter square, and even those symptomatic patients would benefit from an appropriate evaluation by the structural heart team or the multidisciplinary valve team. Paradoxical low flow or low gradient aortic stenosis is a condition that we have recognized more often. This can occur in two different situations, with normal ejection fraction or with a decreased ejection fraction. So those patients who have a low ejection fraction may have low gradients, but their valve may still be very tight, and that can be discerned by using a dobutamine stress echo to differentiate between true aortic stenosis and pseudo-aortic stenosis. But there are a number of patients who have small cavities, thick ventricles, and preserved ejection fractions who may still have low cardiac outputs and have severe aortic stenosis. Those patients need to be worked up with calcium scoring and maybe additional testing like ruling them out for amyloid disease, etc. The reality is that a number of patients, actually even as early as within the last couple of years, as we have looked at the data, more than 40 to 50% of patients with severe symptomatic aortic stenosis are not getting referred or not getting treatment with aortic valve replacement. And this is why transcatheter aortic valve replacement is a very, very viable and lucrative approach for these patients. Medical management and a balloon aortic valvuloplasty, which are the mainstays of therapy for those patients who are inoperable, does not have a good prognosis. This is data from the partner trial that shows that at 5 years after patients with severe aortic stenosis were treated with either medical therapy only or with the balloon aortic valvuloplasty, very few patients survived out to 5 years. This is an animation of the transcatheter aortic valve replacement approach. This is an animation with the Edwards sapien valve. This is using the transfemoral approach, which now accounts for more than 95% of aortic valve replacement. A catheter is placed in the femoral artery, and the aortic valve is traversed with a wire. The valve is then threaded over this wire. The balloon is loaded onto the valve, And then the valve is brought across the aortic valve. While we say it's a transcatheter aortic valve replacement, the reality is that it is a transcatheter aortic valve implantation. The old valve is not removed. A new valve is placed within the old valve, and as the stent pushes the old valve out of the way, there is a new bovine valve that is within the stent that starts functioning immediately. This entire procedure from access to closure can be less than 45 minutes of time. Once the valve is in place for deployment, the heart rate is increased to about 180 beats a minute using rapid pacing. And as this happens, the blood pressure drops in the individual for a couple of minutes, and that gives us an opportunity to implant the valve in the appropriate position. If you can see the animation, there is a little skirt at the bottom of this valve, which prevents any leakage around the valve, which is one of the great features of all the newer valves that are available today. As I said, this procedure takes very little time. It is done now under monitored anesthesia care or anesthesia similar to what patients get for a colonoscopy. More than 95% of patients spend only one night in the hospital and go home the very next day. This procedure was first performed in 2002 in France, in Rouen, France, by Alain Cribier. This patient who had his valve replacement in 2002 is still alive, and that valve is still functioning well. This is the history of the valve as it has progressed from the initial trials in 2005 all the way to 2015, where the SAPIEN 3 valve was introduced. We now have a newer valve of this generation called the SAPIEN 3 Ultra with RESILIA tissue, which we think that allows the valve to last a much longer time compared to the previous valves. The durability of these valves is still unknown, but we know that out to 7 to 9 years, these valves perform as well, if not better, than the surgically implanted valves, based upon data from both the NOTION trial, the Core Valve Registry trial, as well as the SAPIEN Partner 2 trials. This is a second valve made by Medtronic called the Core Valve. This is a self-expanding valve that has also been available for the last almost 8 to 9 years, also done here at the Gates Vascular Institute. This valve has a slightly different design and also has excellent outcomes and very good hemodynamics. So who is a candidate today for transcatheter aortic valve replacement? Initially, when this valve became approved, it was only approved for those individuals who were deemed to be very high risk for surgery or inoperable. Subsequent trials showed that in patients with moderate aortic stenosis, this valve or the transcatheter valve performed as well, if not better than the surgical valves. And beyond that, the low-risk trials also demonstrated the equivalence of the performance of these valves to surgical valves. As a consequence, today, the guidelines state that any individual above the age of 65 who has severe symptomatic aortic stenosis should be evaluated by a multidisciplinary valve team, and transcatheter valve approach should be considered in those patients. For patients who are below the age of 65, typically they tend to have bicuspid valves, and unless they have a contraindication to surgery, should be considered for surgical aortic valve replacement as the treatment of choice. These are the guidelines, and I will not belabor the details other than to say that TAVR has made it into the guidelines across all categories of patients. The important thing about transcatheter aortic valve replacement, and this is an important concept to remember, is that all patients who are referred for a transcatheter valve replacement, in fact, all patients today with valvular heart disease are evaluated in a multidisciplinary fashion that includes a cardiac surgeon, an interventional cardiologist, valve clinic coordinators, anesthesiologists, obviously the referring cardiologist, as well as specialized imagers who specialize in cardiac imaging. So patients referred to the valve clinic at Buffalo General Medical Center get a comprehensive evaluation that gives them the opportunity to not just look at all the different modalities of treatment available, but also then get access to all the latest clinical trials that allows them to try out new valves or new approaches for the treatment of their valve disease. This is the TAVR evaluation pathway, and while it looks complex, the reality is that it has been streamlined to typically one visit to the Buffalo General Medical Center to get most of that testing and evaluation done, and a subsequent visit possibly for a CAT scan or an angiogram if indicated. The typical characteristics of a TAVR patients when we first started are patients with multiple comorbidities, but as I told you, we have now started to treat lower risk patients, and almost any individual above the age of 65 can be considered for a transcatheter valve replacement. The risk assessment for any individual is based upon their STS score, which is the Society of Thoracic Surgery score based upon a database. It takes into account their age, their body weight, their sex, their gender, and subsequently also looks at lung function, kidney function, and a number of other cardiac function parameters like their heart function, the number of blockages in their arteries, the number of valves, disease, etc., to come up with a predicted mortality for aortic valve replacement, to categorize them as low risk, intermediate risk, or high risk. But in addition to the STS score, we look at frailty. In addition to that, we look at other organ compromise. And at this point in time, one of the key determinants in deciding whether a patient has surgical or a transcatheter valve replacement is the patient choice themselves. We want to enter into what's called a shared decision making with the patients, wherein they get all the information about the different modalities of treatment, but we also take into account the patient's personal preference and choices in terms of the treatment that they want. When we look at frailty, it is extremely important to recognize that frailty in the old days was merely an eyeball test where we looked at an individual and said whether they were frail or not. However, today, when we look at frailty, we look at specific, very objective modalities that include a 15-foot walk test, grip strength, serum albumin, and a questionnaire called the CATS Activities of Daily Living. Based upon this, we look at patients as being frail or not frail to decide whether they would have a good outcome with open heart surgery versus a lesser invasive approach. At the end of the day, it is a collaborative team decision which puts the patient at the center of that decision-making process, with the patient preference being as important as the medical issues. The important thing about transcatheter valve replacement from the data standpoint is that these patients show an improvement not only in survival, but also quality of life and their symptoms, as shown by these data from the PARTNER 2 trial that looked at NYHA class, and most patients were in NYHA class 1 or class 2 at 5 years after their valve replacement. And this has been not just in the clinical trials, this is mirrored in our own experience here at this institution, where a number of patients are out to beyond 5 years with their valve replacement and continue to do extremely well despite advanced age. It is extremely important to recognize that the actual procedure has a very, very low mortality. And if you look at the PARTNER trials, the SAPIEN 3 data, the 30-day mortality for patients undergoing transcatheter valve replacement is less than 1%. And again, that mirrors our own personal experience, where we have a success rate in excess of 99% and a mortality rate that's extremely low. The all-cause mortality for this procedure over the last 10 years has substantially decreased, and you can see from the original trials done in the left side of the graph, where the mortality was approximately 6.3% at 30 days, has dropped to 1.6% and even lower in the 30-day data with the more recent trials. The stroke rates are extremely low. One of the big concerns early on with this technology was the risk of stroke. Currently, the risk of stroke is less than 1%. And in fact, multiple trials have shown that the risk of stroke is substantially lower with a transcatheter valve replacement compared to a surgical valve replacement. In addition, there are now technologies that we are utilizing, like the Sentinel device that is placed from the wrist. This is a filter placed in the arteries in the neck that allows us to filter out any debris that may be generated during the valve implantation, which furthers the risk of stroke. Overall, we quote a stroke risk to our patients of less than 1%. Very recent data have shown that the risk of disabling stroke is substantially lower when these filters are used. Major vascular complications tend to be very, very low. Most of these procedures are done from the leg. A CAT scan is done ahead of time to make certain that the vessel size and the quality of the vessel is appropriate for a transfemoral or an approach from the legs. However, if the legs are considered to be inappropriate or too small for a transcatheter valve replacement, additional approaches that include the transcarotid or access from the neck artery, a transaxillary or access from the shoulder artery, or a transcaval where an approach is made from the vein in the belly with a crossover into the aorta, or a direct aortic approach or a transapical approach. So essentially there are multiple approaches for those patients where the leg arteries are deemed to be too small or considered to be inappropriate for transcatheter valve replacement. The size of these devices has substantially decreased over time to where we are now implanting devices using a 14 French sheath, which approximately measures about 6 millimeters in diameter. This is the SAPIEN 3 valve, and which is the most commonly used valve in the United States and at this institution, accounting for about 80% of the valves, and has a design which has an outer sealing skirt to prevent leakiness around the valve, with leaflets that are specially treated to prevent degeneration. These leaflets are made from the outer covering of a cow's heart. The core valve, or the Medtronic valve, is a similar valve, but the frame is made out of a material called nitinol, which is self-expanding, and the leaflets are made out of porcine or pig heart tissue. We talked about the complication rates for all of these procedures. They have come down to very negligible amounts, wherein we feel that even the leakiness around the valve, which was a major concern early on, has come down to very acceptable levels. We know that a leakiness around the valve is associated with poor outcomes. Therefore, we make every effort to make sure that the size of the valve that is picked for the patient is very carefully chosen based upon the CAT scan. The type of valve that is chosen depends upon the calcium and the distribution of calcium around the annulus of the aorta to make sure that we can get an adequate seal, leaving the patient with a valve that is functioning well with no pressure difference across the valve, but also importantly, no leakiness around the valve. This is a quick video of how a valve is implanted, and I will finish with this video. You can see the valve is around at the annulus, rapid pacing at 180 beats a minute. The valve is deployed, and this is in real time. So that is approximately the time that it takes to deploy the valve. The actual deployment occurs in less than 5 seconds. The entire procedure takes less than an hour. Patients typically come in with nothing to eat after midnight. They come into the cath lab. They spend about an hour in the cath lab in the room that they're having the procedure. Once the procedure is completed, they go to the recovery room where they spend another hour and then back to their rooms. A small number of patients who may have prior pacemakers can be discharged home the same day, but the majority of patients spend one night and go home after that. There is a risk of about 3 to 5% of patients needing a permanent pacemaker after the valve is deployed, and there are now techniques that are used to implant the valves high so we can minimize the risk of pacemakers as well. This is the other valve. These are some of the other valves that are used. This is the Lotus valve, which is no longer in the market, and the core valve, which is the Medtronic valve, and this is what the deployment for a Medtronic valve looks like. This valve is self-expanding and sort of deploys itself very slowly. It allows us to pick these valves in those individuals who may already have a pre-existing pacemaker. It is a very good valve to deploy within previously existing bioprosthetic valves. So the bottom line is that for anybody who has native aortic valve stenosis or a previously placed aortic valve surgically that has degenerated, meaning a tissue valve, there are multiple options for these patients to have a valve replacement done with a minimally invasive approach. These techniques have become very prevalent and have become very effective, and essentially are very quickly replacing surgical aortic valve replacement as the modality of choice with excellent long-term outcomes, not just at this institution, but across the world. With that, I'll stop, and I thank you for your attention. And if you have any questions, you can email me or call our office at 716-859-2401.